Minus sir, Mr. Arup Arijit Bhadra sir has already joined. Kindly check the technical details.
Hello, sir. Good evening. Um, we are as of now going on time.
Uh, Good evening. Good evening. Yeah. So,
I didn't get.
hello. So, am I audible? Is my voice is clear?
It's absolutely perfect.
Okay.
Ladies and gentlemen, we will see starting within 5 minutes. Exactly at 4 o'clock we'll start. Very good afternoon, everyone. Am I audible? Hello?
Yes, you are audible.
Yes, you are absolutely audible.
A very good afternoon, everyone. Welcome to IAASLC, an initiative by Shai WB. And today's session is supported by Nestle India Private Limited. I welcome Mr. Arup Arijit Bhadra, Clinical Business Executive, who will represent Nestle India Private Limited, without whose support today's session would not have been possible. A very welcome, sir.
So thank you very much and very good afternoon. I would say rather evening, it's already 4. So very good evening to all the eminent personalities, whoever is attending this very, very important and interesting session. So before going ahead, first of all, I would like to definitely thank 2-3% without whom this session and this thing wouldn't have been possible. So definitely Nestle India is very, very thankful to Speech and Hearing Association of India West Bengal branch, especially Arup sir and Indranil sir, who has given us this wonderful, wonderful opportunity to discuss a very interesting and important topic, which is pertinent into day-to-day practice, especially in the segment that you all are dealing with. Now, having said that, the context that I want to set in this particular thing that uh, this is the particular product which is actually available in outside India for many years, but in Nestle India has brought this commercial thickener concept in this year, and this is a concept which is unique in this part, and the topic that we are going to discuss upon, there's a role of commercial thickener in the assessment and the management of dysphagia, is again a very crucial and very interesting part. And having said that, it's a complex part as well. So definitely a good understanding and a proper knowledge about this particular thing is very, very important for all of us. And having said having said that as well, the speaker who is going to discuss this thing, I can assure all of you, he is the best of the lot who can describe this thing in a very, very simplest way. So Dr. Prasanna H sir is a very, very well known to Nestle family. We all get knowledge, and definitely if there is a confusion about anything, he's the person who is the first one to guide all of us. So this is the time and this is the person who can describe each and every confusion, each and every problem, and each and every who can give each and every solution regarding this particular topic. So again, without wasting any further more time, I sincerely thank Prasanna sir for giving his very, very important and crucial time to help us to understand the concept of usage of commercial thickener in particularly this segment of dysphagia and other this related problems. So that's all from my side as of now. I hand over the stage to you.
Thank you, Arup sir. Thank you so much. And ladies and gentlemen, today's topic of discussion is role of commercial thickeners in the assessment and management of dysphagia. Today we have a very dynamic speaker. We all know him in the field of dysphagia. He is Mr. Prasanna S. Hegde, who is a certified speech language pathologist, presently working in Bangalore since 2013. He has completed his bachelor's in speech and hearing from Dr. S.R. Chandrasekhar Institute of Speech and Hearing, and done his master's in speech language pathology from AISH. He has also completed several certifications post his master's in various specialty centers. He has specialized in vital stem alike. He is currently serving as a program director in the Department of Dialectology and Speech Language Pathology, SPG Hospital, Bangalore. Apart from that, he has also founded SLP Quest, which is an online learning platform of insight rehabilitation, which conducts training and capacity building programs in speech pathology. He is also serving as an associate professor at Nasima Institute of Speech and Hearing. He is member of Board of Examiners in Bangalore University. He is also EC member of Indian Speech and Hearing Association, Bangalore chapter. He is a task force member of Indian Federation of Neuro Rehabilitation and member of Telemedicine Society of India. He is currently pursuing his doctoral degree from Yenagoya University in speech language pathology. He is also Chief Patient Liaison and Technology Officer at Indonesian Medical Devices Private Limited and Dhwani Life Sciences Private Limited, which has developed indigenous voice processes and is focused on developing affordable, accessible, and affordable healthcare technology. He has presented more than 50 webinars, seminars, and many platforms he has made available for the upcoming speech language pathologists also. He has also published several scientific papers in international and national journals. He is also part of several continuous rehabilitation education programs. He is keen in interdisciplinary approach in rehabilitation of neurological, head, neck, and related cancers and healthcare innovation. So we welcome him with open hands, and we are looking forward for a very lucid presentation today. Kindly, ladies and gentlemen, pay heed to his presentation and looking forward. Very warm welcome, Prasanna. Thank you.
Thank you, ma'am. Thank you all for a wonderful introduction. I hope my audio is okay.
Yes, absolutely. Please
Yes, sir. Absolutely. Audio is okay.
Yeah, thank you. Thank you very much. There are a lot of adjectives has been used already, and then I am out of words to tell anything. All I can say is that I appreciate your enthusiasm to be inclusive about me and what I can contribute. I hope I do justice to the topic, and there are deviations which are possible, which I want you to understand in the context of what today's topic is about. And please tell me if the slide is visible.
Yeah, they are clearly visible.
So the assignment that I've got today from one of my guru, that is Indranil sir, is about commercial thickeners in management of dysphagia. It is to set context in terms of what is the kind of usability for these thickeners which are available, which changes the consistencies, viscosity, and other things. So I've combined 3 presentations and made it into a full one in terms of talking about thickeners and also about what are the clinical aspects that we need to be looking at. So there is more and more interest towards dysphagia, and there is more and more material or courses or opportunities available for you to specialize in each thing. But one should not forget that the basic knowledge has to be done, or in terms of what is the context of every topic that we talk about. So I'm going to look at certain aspects of dividing this presentation into multiple levels. The first one I'm going to talk about is consistency decision in dysphagia management, and what are the things that go on, and how do we look at consistency as a suitable fit during the course of care or care continuum in the patient's timeline. So the scope of this, the first few slides, that is around 20 slides, is going to be physiology of swallowing and dysphagia and nutrition. And this is not, I'm not here to discuss about what are the stages or what kind of dysphagia or pathophysiology or what is the nutrition that needs to be looked at, but it is going to be in the context of safety and efficacy continuum, which is going to be looked at in terms of what is the usage of these thickeners, and consistency and strategy relations. That means how does consistency differences can relate to the strategies or the swallowing techniques that are going to be used in dysphagia management. And the last one was going to be how does consistency modification as a standalone strategy fare when we are wanting to have immediate success for that, so that patient has better adherence. So at the end of this section, we're going to have some of the videos that is looked at in terms of how the thickeners are going to work. So let us put a context in terms of patient-reported outcomes. So every presentation these days of mine comes with the patient-reported outcomes because that is what is the mandate for us, or that is what is the gold standard for us. what the customer feels or what the patient feels or what the end user feels is going to be my target. So what is the general belief of any person who walks into your clinic is that if the diet is not regular, then it is not normal. Usually when you ask the patient, do you have food? Then they say no. Then how are you surviving? You don't have a tube. Then they say, I am having liquids. Then my argument with them is that isn't liquid also food? Then they say, no, that is not food. That is something specially prepared for me, but it is not like how others eat at home. That is the kind of mindset everybody comes with. And that is true. That is what is the goal for us in terms of what we need to be achieving at the end of our treatment. So the continuum of consistencies are these, any thickener discussions or any consistency discussion has to happen in the framework of ITSE because the world is changing towards this. Now we know that it starts from 0 to 7. There are 8 levels of consistencies. So first one is thin and the last one is regular. So where does this thickener fit? So for us, the thickener is something to do with, with the liquids, and also there are other usage of increasing the smooth flow or smooth transition of the food at level of 3, 4, or 5 when it comes to transitional food or the regular food when it is not liquid. Okay, so basically we are going to look at liquids as the mainstay of our discussion when we talk about thickeners. So why is there a red mark here? So this is where we are going to start first for a patient. Let's say a patient has had a stroke or has undergone a surgery for any carcinoma in the oral cavity or any part of the head and neck region. So the first bite or first sip is going to be one of the consistencies which is deemed to be or which is understood to be safe for the patient, or also the clearance for maintaining the aseptic nature. So if it is head and neck oncology, we would generally start with water. And if it is stroke, we would generally start with thick liquids. Now, that thick liquid decision should be based on evidence on terms of that should be the highest safety. And also it should be proved using an instrumental evaluation. Otherwise, you cannot have a blanket decision saying that all stroke patients are going to have slightly thick or mildly thick as the first introduction of consistency of food when they start eating. So now, how do you look at this framework to make sure that you balance between safety and efficiency? Now, there are two things here. Now, you know that thinner the consistency, the flow is faster. Thicker the consistency, the flow is slow. It gives you adequate time. Now, how are you going to make the differentiation? Now, it is based on what is the clinical finding that you have. Are you going to look at aspiration as the factor? Are you going to look at residue as the factor? That is something you need to look at. Let's say if it is aspiration, and aspiration happens before the swallow, that means food is reaching the laryngeal area before even the person attempts to swallow. That means the liquid is flowing fast and the patient is responding slow. There is no control. At that time, if you have a thicker consistency, the thicker consistency is going to give you some more time to react or be ready and swallow those consistencies and send the food in the right direction. Similarly, when it comes to residue, now thicker the consistency, higher is the residue. Now, if you are targeting to reduce the residue, immediately you are supposed to have a liquid wash, or you have to restrict yourself to the thinner consistencies. Now, can we do that in a real scenario? Like I said, the patient will not be happy for long if the modification is done. So what we need to do is when we parallelly work on the strength of oral musculature and pharyngeal musculature to reduce the the weakness or increase or improve the muscle engagement, we'll also have to give a quick fix with the help of viscous or cohesive bolus, which can be done using thickeners, which keep the food together, and the slipping of these food quantity for food items will be much easier. Okay, so that is how we are going to balance safety and efficiency by deciding whether you have to go towards the liquid side or towards the solid side. So now, how does consistencies and physiology physiology of swallowing relate. Now, when you look at food delivery, the access to the oral cavity is very important. Let's say a patient has less mouth opening. We cannot force the patient to eat solid food, which is going to be bigger in size. Now, if he has only lesser than 1 centimeter mouth opening, he will have only liquids, something which can be easily delivered in the mouth. When it comes to mastication, let's say lateral movements are not possible in total glossectomy, then we cannot expect a person to have something which needs mastication. Similarly, bolus hold, if the liquid is there, if the tongue control is not good, the bolus, if it is getting spilled either anteriorly or posteriorly or towards the lateral side, this becomes a difficult task. So liquid bolus becomes an issue when it comes to affected tongue control. Similarly, other aspects are there like oral and pharyngeal propulsion. It either relates to the quick movement of these propulsion, which relates to safety of swallow, or effective movements or the strength of the movement against each other, which is pharyngeal peristalsis, which is going to continue as esophageal peristalsis. So these things are also important in terms of deciding about what kind of consistency to be used. And about esophageal entry or clearance, which requires the lead pressure. Now, liquid requires lesser space to pass through, but the solids require higher space, or even it exerts higher pressure on the upper esophageal sphincter. If the closure or if the obstruction at that level is more, then the patient is going to be constrained towards the liquid diet. They will have difficulty in having solid diet. What about tail closure, or what about the pressure that is behind the food? That is also required for us to clear the food, and control any backflow of these food. Now we've seen that in the patients who had deficits in velar movements, thinner the liquids or thinner the consistency, the nasal regurgitation is higher. So that is when we tend to use slightly thicker consistency so that the immediate solution is given to the patient, and then the patient goes on to improve the control for even thinner liquids as well. Similarly, about airway safety, again, we already discussed about thin liquid requiring higher control is slightly more riskier to control and more riskier towards safety than something which is thicker. It is not always true. It also depends on what is the cohesiveness of the consistency and how well the food stays at the border of the pharynx, rather than just jumping over the epiglottis and entering the laryngeal area. Speed of the food, that is also is important. Now, viscous fluid or more cohesive fluids can have less friction around the area there, so it becomes easy. I'm going to present a small pilot study that we have done initially as well. And sensation, now if there is no sensation or affected sensation, or there is modification in the consistencies, even when we use thickeners, it is going to give a different feeling. The patient might like it or might not like it. So that's what I was talking about in terms of what the pilot spoke about in terms of who probably will be adhering to change in these consistencies. I would say whenever a person has a problem, that is when the patient is going to be adhering to the instruction that is given. Even when the modification is not palatable, they are going to follow those things because they know that effect of these things are going to help them swallow efficiently and safely. Now, about consistencies and strategies, how are these swallowing manures are also related to this consistency? If you look at supraglottic swallow, something related to a non-physiological approach, and you are going to add cough to the swallow, voluntary cough, so that whatever enters into the airway, it is removed. This generally happens with thinner liquids because it flows faster. That is why you ask the patient to hold the breath, swallow, and then cough out, because you know that there is immediate aspiration for thinner consistencies. Now, what about effortful swallow? So thicker, the more headache. That is when I said that thicker consistencies are going to be leaving more residue than the thinner consistencies. That is where you need to look at effortful, swallow for these kind of things when you want to tackle the residue. Speed-related strategies, that is thinner, the more challenging, because you need to look at bolus hold. It has to reach when the larynx is ready. Otherwise, there is a wrong entry into the larynx, which is going to cause choking or aspiration. Strength-related strategies, which is similar to effortful swallow, thicker, the more power consumption, and also there is requirement of adequate coordination from all the muscles to have the squeeze. Now, let's say if you're looking at a weak person, or let's say a patient who's in, above 65, having the, frail body, they probably will have difficulty in thicker consistencies or even solids where they cannot exert that much of pressure. And the next one is electrical stimulation, which is going to be relating in terms of speed and strength at which the contraction happens, at which the hyolaryngeal excursion happens. How are we going to look at the outcomes in this electrical stimulation? What kind of consistencies would relate to these kind of things? Now, if you're looking at initiating the swallow reflex, liquid relates much better when compared to reducing the residue in the pharyngeal cavity, which relates to strength of that squeeze. Similarly, thermal, which is going to be related to initiation of the swallow, which is temporal in nature, or which is the speed with which the body responds. And then lastly, the texture. For better clearance of the solids, you need to have a feeling in the pharynx so that the body recognizes that there is something and I need to clear it. If I don't have the awareness of things that are there in the pharynx, I will not be able to clear it. And there are certain patients who will hold the bolus like in a bowl in the pharynx around the laryngeal area. And whenever there is a movement and whenever there is multiple swallows, that stored food might get spilled into the airway and cause problems. So that is going to be post-swallow or delayed aspiration. What do we do with our goal, or how do we set our goal in terms of what we do in the clinics, in dysphagia management? We are looking at quality of life, maximize the variety. We may not be able to achieve all the consistencies for all the patients, so we'll only look at maximizing or probably having progressive improvements in terms of our timeline of treatment. Nutrition, it's always said that thicker the better. The patient is able to have thicker consistencies. You will be able to deliver more nutrients and protein intake without the burden being on the caretakers for every 2-hourly feeding, as in the enteral feeding. Hydration, thinner the better. Now, if the patient is not having anything, any fluid, the patient is only on soft diet, because there is safety issues with the liquids, then the patient will have dehydration. So in those cases, it becomes challenging for us that we have to look at making the availability of water for the patient as well. And that is when you can use thickeners and deliver hydration to the patient as well. So better coping of symptoms during treatment. So that especially in the patients where who are undergoing radiation therapy, they probably have discomfort as a symptom when having food. The underlying principle of prophylaxis in these kind of patients is to have as much as possible food orally as long as possible. So this is the basic principle for us to finish the treatment at the highest baselines. That means when the patient finishes all the oncological treatment, the patient should have less and less problems in swallowing. So when that is achieved, we will be able to reach our goal to the maximum in terms of delivering all kinds of variety for the food. So in such cases, the thickener helps in terms of increasing the comfort by reducing the pain or discomfort or the time taken during these activities. And patient not cooperative, always it is a problem for us in terms of tube feeding. Sometimes even when we know that liquid's going to be a problem, even when it is thickened, the patient is not willing for a tube feeding, then the only alternate thing we have is to deliver hydration with thickened liquids, which is going to be less safety issues or less, less problematic for us when compared to thinner liquids. So now, what are the benefits of consistency modification as a strategy itself? Is that there should be adequate knowledge about all the aspects that we look at. These are the following things that probably can be used as consistency modification as a strategy itself. Whenever there is poor hydration, you can always use a thickener and make the water available in the thicker form. Poor nutrition, this also in terms of providing those nutrients. If, let's say if you are giving milk is going to coat the pharyngeal area, and that coated material can get mixed with the saliva, and it can enter the airway and it can cause problems. So those things are also a problematic issue. So thickeners usually does not mix for some durations when it is when it is given. I'm going to show an example with a fiber optic endoscopic evaluation as well. So there are issues like delayed medication absorption, where that a person is on capsule and the capsule is supposed to dissolve only when it is in the gut, not in the mouth or not in the esophagus. So you can use thickeners which are going to be encapsulating in a virtual manner. It is not exactly like a capsule, but it does not allow the content to get mixed with the surrounding that easily. So impact on quality of life. Now, if the patient continues to have oral, that is much more or much better quality of life for us than the patient on the tube, which is going to be a social issue as well as aesthetic issue for his interaction with others. Caregivers' perception, again, tube feeding is considered to be a bad thing. Looking at oral alternatives, how we can modify using the consistency modification. Costs associated with modified diets. There are availability of natural thickeners like starch, and the only issue with those things is that there is taste change, and the arrowroot products are also available. Some claim that there is no taste change, but also there is nutrient change that happens with some of the products. However, no matter what the thickener is going to claim about whether they do or they don't do, it is about our clinical understanding about what we exactly want. If we can convince a patient, palatability is not an issue at all. It's only about the patient perception. It depends on how well you explain, how well you weigh the benefits of continuing to have oral versus not able to have or being in an enteral fluid. So these are all the things that we can use as a modified consistency as a strategy as well. So what are the statements for argument, in terms of looking at use of this modified diets or thickeners? Now, we know that more and more studies are coming out and say that there are not much of or not conclusive evidence in terms of using these thickeners, or there's the diplomatic way of saying is that there is no conclusive evidence. So not telling that there is no evidence, or they're telling that there is evidence. So these are the statements that probably can be explored much more. And some of the examples of statements are modifying diets as a rationale for pathophysiological basis, a rational pathophysiological basis. So we look at bolus hold as one of the factor. We want to slow down the movement of the food to the pharynx. So that is one of the rationale which we're looking at. And somebody can say that, if the thickener is used, that becomes slippery and it might reach the pharynx much faster than the water would flow. Those are all the physiological aspects that we need to validate using an instrumental evaluation and see whether it is really true or not. In our experience, it does not go that fast. It requires the patient to, push the bolus towards the pharynx. It does not flow that easily as well. So evidence-based decision making is not just about clinical trial evidence. Now, we've been basing our clinical practice looking at clinical trials that has happened. Most of the clinical trials have happened in the West or in, outside of India. And we look at those things as one of the main guidelines for us to decide anything. We are not looking at anything that our clinics or our patients are telling us that this is what my need is. So I think we need to look at case-based evidences to be available for us to make a judgment. The same treatment with the same profile of disease and dysphagia may not work with the other patient. So that is how we need to look at modifying our things. We should not always look at clinical trials. So this is my opinion. You can have your own. You can have the argument. Probably at the end of the talk, and we can probably have a fruitful discussion about it. So the third statement is modified diets are justified if consent is obtained. So there is one of the statement in the consensus or the position statement which came out saying that before you use a modified diet, you're supposed to take a consent from the participant. So now that is not just enough. You need to give a reason on why we are using it, what is the need for it, and how is it going to impact in terms of both pros and cons to the patients. Is it going to be financially burden to them? So are you going to weigh the benefit of the safety and efficiency of this food more than the burden of uh, taking it in home, mixing it, and refilling it every 2 week once? So is it going to be less financial burden than the benefits of it? All those things needs to be explained to the patient, and then consent needs to be obtained. So there are exceptions to the need for research evidence, some of which can be looked at as anecdotal or our experience in the clinical aspect. So that is going to be the argument, which may be taken up. So why that is relevant is because now, let's say I've seen a patient and I see that one of the technique or one of the strategy has worked with that patient well, and the patient is happy, and that is proven in the instrumental evaluation. But if it says otherwise when compared to any of the evidence that is there in the literature, that is still a good evidence for you to go ahead and keep trying this technique until you see that you have a good amount of literature, data, so that you can publish those data. That is also an important thing. You don't have to look at research evidence for every use that is there, even when you see some things which is not mentioned in the literature. And there is another scenario in this, that whenever a product comes or whenever a strategy comes from the West or from other countries to India, we look at understanding the Western literature, and we know that okay, it is working there. Now, what is the need of conducting a research here? There is different kind of opinion on this. Yes, we are culturally different country. Probably we need to look at validating those things in the cultural settings or socioeconomic settings, but scientifically or physiologically, that is going to work similar to us in terms of how a thickener can benefit a patient or can have problems in terms of what would happen if it goes into the trachea, whether absorption will happen or not, what kind of bioavailability of water will be there. So it is going to be the same, unless somebody has evidence in terms of in different temperature or in different temperate conditions or different climates, these thickeners are going to behave differently. That is what you need to be looking at in terms of evidence when you look at replicating those studies in India. So now, how do we balance in terms of decision making? Both safety as well as efficiency is important. Now we need to look at nutritional value as well, and also have burden reduced whenever you look at prescription of these things. So these are all the clinical aspect that you need to look at. How are you progressing from FOIS 1? FOIS is functional oral intake scale, which is a scale that tells you where exactly the patient is in terms of oral. So 1, 2, 3 is about tube feeding with increasing amount of oral feeding, and 4 onwards you have oral. 4 is single consistency, usually liquid, and 7 is normal diet, where 6 also is normal diet, but some restriction is allowed. And it could be a diabetic patient or a person has intolerance to spices. All those things can be looked at. So now we have to balance between safety and efficiency. Why safety is towards 1 to 3 is because liquid has difficulty in holding the bolus together. That is why spillage is possible. Efficiency, that means residue increases with the increased consistencies. Again, about nutritional values, thicker the consistencies, better the way, better opportunity for us to deliver the nutrition. And also burden is also there somewhere, letting us know that we need to take careful decisions, consensus about what the patient is going to benefit about, when compared to its cons. So some of the videos which are going to tell about the clinical aspects. So the first one, the patient, there are multiple things that are happening in the oral cavity. This patient received radiation therapy, which the patient
Put your head down.
appreciating oral fluids. Patient is not willing to do anything because there is a lot of discomfort. You see that patient is struggling to operate in terms of
So relax. Relax.
but
Not doing anything yet.
for the patient. Look at the lips, there is already ulcer. Now, we didn't want to delay the oral intake till the ulcers reduce, because that is not going to be reducing based on whether I give or not. I'm maintaining good
Already inside.
clinical achievement in terms of consistencies at the earliest. So we are at the pharynx right now, and we are able to look at the pharyngeal cavity. You see a lot of ulcers in the pharyngeal cavity. There is edema as well. Right. So why this video is relevant for us is that when we looked at saying whether the consistencies were clear, safe or not, we straight away used HC level 2 consistency and saw whether we can easily give it or not. See this, you see the flow of HC level 2, although it was flowing before the swallow was initiated, it was still safe because it contained in the valvular area, did not spill anywhere. And post the swallow, we asked the patient to say E to make sure that there is nothing in the laryngeal cavity, and the patient was able to say E without any change in the voice, perceptual change in the voice. So why only HC level 2? At this point, we just wanted to start single consistency without looking at over enthusiastic initiation of everything, because we know that the patient is under tremendous discomfort because of the ulcers, and we just wanted to make sure that patient is adhering to the things that we are telling right now, and then probably introduce something else later. So this is another patient. This is a patient who had a stroke recently, and when the patient was on and could not be decamped.
उसको बंद करके सांस लीजिए आप आराम से, सांस लीजिए ऐसे नॉर्मल सांस लीजिए.
Yeah, so we are basically checking on what is the areas, the probable risk of aspiration. What is this portion? Interarytenoids are the risky areas for us. If at all anything spills, because there is adequate bridging at the erythropoietic fold. So we went ahead and gave consistency. We asked the patient to hold the bolus in the mouth, wait, because we were doing sensitive evaluation there. Now we were trying to touch on arythenoids. There was no response at all, no cough at all. So we went ahead and gave consistencies. The first consistency that we gave was patient did not have any response. So that there is intra-arytenoid spillage that happens, then later on swallowed, then cough at all. You know that there is silent aspiration, significant amount of bolus is going down. To pause at the time that we Yeah, so that is the point when we saw that the bolus, a small amount of bolus was going at the level of interarytenoids and going towards the airway. So this is a silent aspiration. So what is the relevance of
gone down.
is that the cohesive nature of the bolus. Now, if you look at this,
Sensing.
any possibility of aspiration is high.
ठीक है आप मुंह में रखिए
Whenever you use
ठीक है
resistance thicker than this,
अगेन निकलिए निकलिए
you see this.
नहीं आप वो जो है निकलिए अभी और एक बात
Later, there is no
on command
interarytenoid spillage that is happening. So only on commands the patient is able to swallow. And even the patient is not able to recognize whether there is residue in the pharynx or not. So this is the same patient.
नीचे देखिए निकलिए
So there is another video. What this is about.
thick consistency
Some amount of saliva which is there, which is the risk of mixing with the food which is there, and it probably remain back. Treatment of the range is also important in terms of whether it will affect the movement of pharyngeal structure. See this, in this, the patient is having aspiration. It is not flowing as the water would flow, remaining at the level of supraglottis and is able to cough out. It is cohesive in nature, so this is what you would want to expect from a thickener. It remains cohesive and then it should be able to move
ಜೋರಾಗಿ ಗಟ್ಟಿ ಉಸಿರಿಡ್ಕೊಂಡು ನುಂಗಿ
So this is another patient who was on medical oncology care, the lung metastasis. So this patient was having aspiration even with thickeners at the level of ITC level 2. We increased, I'm not sure if the video is clear, we increased the thickness, thickness to ITC level 3. The patient was already on the tube, so we were not worried about the availability of water, but we were looking at something more cohesive in nature, like the consistency of HD or puree. So we increased the consistency and gave the patient, he was able to comfortably have. But this is the clinical or evaluation scenario. We did not know what happened to the patient in the ward in terms of whether he was maintaining the proper position or not. Here all the positions were maintained, but apparently the patient was sleeping and trying to eat khichdi in the ward. Unfortunately, we lost this patient. The reason is still the gray area for us, whether it is the lung metastasis that is or there was constant aspiration that was happening, which might have been ignored earlier, and then the time when we looked at doing the assessment, probably it was chronic level of aspiration that we have reached. There's another the patient who had was undergoing
ಇವಾಗ ಬಾಯಲ್ಲಿ ಕೊಡ್ತಾರೆ ನೀವು ಅದನ್ನ ತಗೊಂಡು ನುಂಗ್ಬೇಕು ಓಕೆ ಒಂದ್ಸತಿ ಇದು ನುಂಗಿ
hypopharyngeal mass that is there, then the patient did not have very severe aspiration, although for liquids he had aspiration. Now in this patient, because of the congestion in the pharyngeal region, there is higher risk that epiglottis will not close. Now if epiglottis does not close, now you see that there is aspiration happening for this patient. The patient is coughing out, and if it is thinner liquid, there is higher chance of aspiration or entry into the airway when compared to thicker liquid. So this patient for validating our views, he was on solid diets, no problem at all. But whenever he had thinner consistencies, the patient had issues. And this is the last video. So again, there was aspiration. You see some of the amount which is there in white color. Okay, now if you look at the first part, see some amount, not discoloration is not.
Opposite side okay.
The thickened liquid does not mix that readily with the saliva. Okay, we are taking ice cream. It's going to immediately mix with the consistency. Coat that much when compared to milk content. Although aspiration may not be that less, but controlling the bolus and getting later.
Okay.
Yeah, there's one more video, I think. Sorry. So this is a patient who was profusely aspirating, but once we gave, thickened liquids, the patient, this is the saliva that is collected there. Now we are looking at giving thickened liquids because we wanted to make sure that we differentiate between aspiration to saliva versus aspiration to food. The patient was aspirating on saliva because physiologically it is unrecognizable unless it reaches a level. It tends to stay there even when the patient aspirates, and probably the patient will clear the throat, but not like how he would do for aspiration to the food. Let's go to the level where give. Yeah, so this is the consistency that we gave, which is higher than thickeners. This is a solid consistency. Now you look at the consistency, it is not cohesive. So some part is there, towards one side, some part is stuck in the vallicula. The patient is not able to clear. This is I think this is a khichdi that was given. Now in this scenario, so we'll have to look at giving thicker consistencies which are more cohesive. You see the grains that are there. So here also we can look at utilizing thickeners with the consistency that we already giving. You see in the last part of it, although there is mixture with the khichdi, aspiration amount is reduced, because of the cohesiveness. I'm not sure if the video was clear. You can play it probably at the end of the talk as well. I'm going to skip some of the videos. See if this is okay. Yeah. So here is the video which will show you the separation of thickeners when they're closer to not readily mixing. Aspirating saliva, thickener is staying separate. It is not really entering the airway, but it may not continue to stay there. It must, like, over a period of time, it is going to mix with saliva. But if you use some strategies so that you can get cleared from the pharynx, the risk of aspiration gets reduced. Now coming to some of the case scenarios for radiation therapy in terms of not related to aspiration. Now we look at radiation therapy as adjuvant setting and concurrent setting. Now any radiation that is given to tissues is going to have side effects in terms of whether how much dose is going to be used, based on which mucositis grade will change, and that is going to be acute problems, and then later it's going to be fibrosis or wound healing issues. So how is that going to affect swallowing is something which is a very interesting aspect to look at. All this while we've been looking at safety and efficiency in terms of whether there is aspiration or not, or whether there is residue or not. But effort, pain, and discomfort while swallowing is also an important aspect. If you see a patient with radiation, who's undergoing radiation therapy, he may not complain of any of the, aspiration-related problems like choking or cough. The patient just refuses to have anything because it is burning in his mouth. He's putting more effort. So we use this scale to check the different feelings of feeling during swallowing different consistencies, and the patient is supposed to rate individual questions or individual statements at using a visual analog scale, which goes from 0 to 10. 0 means there is no discomfort at all or no effort at all. 10 means even with effort it is not successful. So how do we use this process for radiation? So we look at using these things in terms of first assessing whether there is any change in the timing or the duration of swallow or not. What we do is that we give 100 ml water swallow every week when the patient is undergoing radiation therapy, and we keep noting down the number of swallows and the duration required to complete this 100 ml water swallow. And then we keep noting it down whether there is any increase. And in all our patients who undergo radiation therapy, they said that there is increased effort and increased duration of the consumption of this water. Now, the moment they hit a area where that the patient is going to go to the tube, the enteral feeding site, or the radiation oncologist is wanting to halt the treatment and give rest and admit the patient for supportive care, that is when you're going to use thickener and see if you can stretch the oral intake for some more time. And we did it, and we were able to achieve 2 more weeks of continued oral intake in those patients, so which achieved our goal of as much as possible and as long as possible. So that is what we talk about, finishing RT with the highest baseline. Probably we should not wait till the threshold level. Probably we should start much before, so that the nutrition and other things and all taken care properly. So we looked at conducting the use of thickeners on or the feel of thickeners in some of our colleagues. We took 12 volunteers. We gave 100 ml water, regular water and thickened water, and we tested what is the kind of change in PD scale. P is, that is pain, effort, and discomfort. And there was no pain, or the difference in pain was not there between the regular water and thickened water. Effort was much less for TUC, that is thicken up clear, which is 83% of the population said that it was better. And discomfort was less for regular water, because the patients whom we took, or the volunteers to whom we took, they did not have any problem when swallowing. So when they don't have a problem in swallowing, any addition which is going to improve swallowing for a patient is going to be a burden for the patient. So that is when it comes as the information given to the patient, giving them a perspective or giving them a foresight about what is going to happen later, so that their adherence to thickener is much better. So this is what I told, that only when a patient has a problem or patient has cough, and when you use thickener and it is reduced, that is when the patient is going to believe that thickener is useful for them. So that's what you need to be looking at, carefully. So these are case scenarios. Now we are going to look at other alternative aspects of usage as well. Now we looked at discomfort, we looked at pain, effort, and also aspiration related aspects. We're going to look at another case. This patient underwent wide local excision, marginal mandibulectomy, coronarectomy, and all possible resections, PMMC flap, tracheostomy, and the patient was unable to be weaned off of tracheostomy dependence and had difficulty in swallowing as well. Both breathing as well as swallowing was a concern, and the patient was going towards being a dysfunctional larynx, although no treatment was done to the larynx. Now, assessment we did on, for corking trial, 10 minutes, the patient was okay. Speaking well, 2 to 3 hours, he was okay. And we did a video. There is reduced edema in the supraglottic structures from the previous visit. And there is also, the pharyngeal edema, which was reduced from the last visit. Blue dye test was done to, see if there is any aspiration. There was refer for colored water, but we started using thickeners to test these risk of aspiration. And that is when we realized that if we can start off with any consistencies safely, that should be the first step for us towards progression. And we thought that ITC2, when we use, there's again reduced amount of aspirated amount through the tracheostomy tube. When we use ITC3, the patient had no aspiration and also patient was comfortable. So this gave us a clinical scenario of usage of thickeners, even when there was aspiration or even when the patient was having both breathing as well as swallowing difficulty, unable to be weaned off from the tracheostomy dependence.
But it has reduced compared to last.
The glottic things that is available for the patient. Okay. For us, clinically, this was sufficient to become late. And since the patient was okay for HT level 3, and the patient anyways was on we can if later on we can take up the rehabilitation of other consistencies. So another case here, CL larynx, the patient underwent total laryngectomy in 2022. He came to us post stomoplasty and TP change. Immediate change, the TP was not possible as it was just placed 2 days back and it was leaking. And what we did is we used thickener in place of water, and there was no leak found. So we were able to comfortably send the patient home till we planned to change the TP. Because of the consistency, it did not leak, and still he was able to continue to have water in thickened form. So another case, similar one, there was no leak for ITC level 2, and this is the example of one of the leaks that was there for a patient, even when closing the
Enough.
Here the consistency used was ITC level 0.
Because of pressure.
So in such scenario, using a thickener will help us reduce this leak and send the patient home even without changing the TP in difficult cases where we cannot change the TP. So this is again another case where the patient had pain while having water. The patient complained to us saying that he will not be able to continue to have. Probably he will NG tube needs to be placed, or it was already in place. Probably we would look at removing it once the patient is comfortably taking the water. But the moment we spoke about, we did test it, ITC level 2 with Thicken Up Clear. We saw there is improvement. The patient also reported that there is improvement. The moment we informed the cost, the patient said that, yes, I'm going to try water for some more time, and if it does not improve, I'm going to use Thicken Up Clear. And then patient never returned back. Now we know that patient is on regular diet post the surgery and radiation. Because of this motivation of the cost, they are still able to make differences. So this is not so positive thing, but yes, it is going to affect in terms of what are the modality you have, how valid you are as a clinician. Let's say if a patient complains, you have a solution to give, whether it is true for the patient or not, or whether the patient is over exaggerating or not, you will still be able to treat the patient adequately as the patient would require it. So again, this patient had better swallowing with the regular diet rather than the Thicken Up Clear. So although change in effort was there, no change in effort was there. We educated the patient to have as much as oral possible, and the patient could not have any difference in terms of water or Thicken Up Clear. So this is one of the example that not necessary everybody will have the same kind of response. Now you should look at what stage that is there. Now you look at the radiation therapy stage, it is fraction number 3, that means 3rd day into radiation therapy. The patient does not yet have any issue which is because of the radiation therapy. The complaint is from the beginning and it is surgery related in terms of scarring. So till the patient does not get discomfort because of pain or burning sensation, you will not be able to have any benefit from Thickeners or thickened liquids. So these are our experiences. So TUC helps in prolonging oral diet through the radiation therapy. Thickeners reduces pain during swallowing of water when thickened if there is a problematic regular water. Thickeners increases discomfort if there is no problem with water, because patient thinks that it is a burden for them and palatability is not that great. And TUC improves comfort and helps in prophylaxis, which is going to be smooth and cohesive. And beyond the last few case studies, it reduces the instances of aspiration, although we'll not be able to show with videos from pre and post and the kind of aspiration. We were able to look at how slowly the thickened liquids was moving rather than the water when it was aspirating, or the saliva which was going down the airway between both the arytenoids. So you can use to validate this using blue dye test. You can use FEES or video fluoroscopy to test it, and it can also reduce degree of aspiration of liquids by reducing the speed or the distance it covers for unit time. It can reduce the speed of post-swallow aspiration again, which is similar to the previous one, which is going to be much helpful for us to manage by using strategies. And also it helps in better expectoration or help in reducing the supraglottic residue, which is going to remain when multiple swallows happen. So this is going to be our clinical utility. There are still more scientific things that are there which look at clinical implications of changing consistencies, which we are not going to look at today's presentation. So I hope I made my point clear on the clinical utility of the thickeners for our clinical practice to help the patient swallow better. Thank you very much, and I can take some questions.
Thank you so much, Prasanna. As always, your presentation with so many live examples, the trendsetter. I have few questions to put to you. Number one is, the thickness actually increases the viscosity, right?
Yeah.
Yeah. So what is your experience dealing with the patients with glossectomy who have a restricted tongue movement? What is your experience? Does this increase in viscosity have any impact on deglutition, or is it smooth?
Okay, so now if you look at patients with glossectomy, now you cannot look at just the oral cavity, because we know that in oncology, you look at having an operation as well as following up with radiation therapy, and the effect is on pharynx as well, because neck is covered, and it is not an isolated problem. So when we look at increased in viscosity, the viscosity is not just about the flow, it is also about the friction that is reduced on the surface. Now, if you look at the thickened liquid, it looks like a jelly. What does the jelly means? It is going to hold all the content together. It slips easily. So when you look at the pilot study that we did with 12 volunteers, the effort required to push down the ITC level 2 was much less when compared to water. That's because it is the cohesiveness also that is the matter. It's not just about viscosity. So in glossectomy patients, we see a lot of use because they are going to have problem in sensitivity to the thinner liquids, because it is going to flow fast, and it has problems in bolus hold. They cannot hold the bolus in the mouth, and also the flow of the thicker consistencies is much better when compared to any other extremely thick consistencies or ITC level 3 which you can take. So it is easy for transition of food from the anterior portion of the oral cavity to the posterior side.
Excellent. Thank you so much. My next question is about dealing with patients who have problems in ingestion of tablets and capsules. Can you guide us how to take about with this kind of patients? What do you do?
Yeah, sorry. So, I'll give you a case scenario. So there was a patient who had problem in taking tablets since the childhood. Now they came to me and they said that they're going to look at they expressed the concerns to me. I used all possible techniques, all consistencies, to see if that capsulating, the virtual capsulation of those tablets are going to be, especially this Dolo 650 or the longer tablets. The patient did not have any improvement at all. So then I realized that the husband of the patient actually told me that, sir, don't break your head for this. This is psychological and the patient has been having this problem since the childhood. Now, what does the message of that? Now, if I don't have the patient confidence attained before I try anything, it's going to be difficult. Now, let's say if there are other patients who came to us. Now, we gave the tablet just like how we would feed the pets, and now we put capsules in the dosa and give it. There are some clever, people who are going to take out especially our kids here, if at all there is any tablets or all things, they will just spit it out. Now, if the patient wants to really get help from it, especially if it is capsules, which is going to be late delivery in the gut, they can try with thicker consistencies, especially if it is EC level 2 and upwards. It is going to help us transition from oral cavity to the pharyngeal cavity, and then there onwards to the gut or the esophagus or stomach. Now, how we can do that? It's not just by we have thickener mixed and then we take a sip of thickener and then we put the tablet. No, not like that. So we are supposed to put the thickener and put the tablet and then mix it, because the capsule will not easily get dissolved in the thickener. So it is going to stay. It is going to stay like that. And, because it is going to stay like that, it is going to take some more time than the water when it goes directly into the liquid. So you put some effort to mix it. And then when you consume it, it is going to have release in the stomach rather than in the mouth itself. So it has to be mixed as well. It has to be blended as well. It has to, not that you just put it on the thickened liquid and then try to take it. No, it will not happen. So you have to give enough time for the capsule to get into the thickened liquids and then take it.
Regarding the capsule, there are some multivitamins the shells are very thicker compared to other capsules. In that case, what you usually do, remove the capsule cover, or what you do exactly?
See, capsulating is about where exactly the absorption should happen. And there is also palatability, which is questioned. Some of the content of the medicine is not going to be palatable. So you'll have to understand those things and then look at using it with the thickeners. Now, if it is thicker, that means it's supposed to release later. So in multivitamins, as I know, it is about the palatability as well. Now, not all the multivitamins, when it is in the medication format, are going to be, you even get some, strange smell when you burp. So those are all going to be the problem.
Right.
Now, if you mix it, you don't have to take out the capsule. You just have to, stir it once in the thickened liquids and then take it. It becomes easier.
Okay, that's a nice solution, right? So it will not add on to the bitterness, but at the same time, it will be easier to take it in.
Yeah.
Next question is, there's a lot of, thinking around that there is a lot of bloating associated with thickness. What is your point of view on that, and how do you address that?
See, I have not heard anybody tell about, any of the patient complain about this thing. But yes, there are reports about satiety and, after drinking, you feel like, fullness is there. This is the case in any fluids that you're on. Let's say if you're on a fluid diet, if you're on enteral fluid as well, and enteral feeds as well, you're going to feel like you're, you are full, always, there is no nutrition, but fullness is there because of the water content. We have not heard anybody speak about bloating. I'm not aware of it. If Arijit has any technical points towards it, he may be able to give that point. According to me, there is no bloating effects, because of the thickeners.
Yes, sir.
Maybe the
I would like.
terminology the patients are using. Yeah, yes, sir, please.
No, I would like to echo the same thing. So many patients have been using right now this thickener clear, so there is no such incidents or cases like bloating in this particular thing.
Right. Okay. That is, if anybody has any questions, please put it in chat box, or you can directly ask also. I think the presentation was well drafted. It was well understood. We can wait for 1 minute and then we can go on. Okay. I would request Indranil Chatterjee sir to kindly come and address the session, please, sir.
Am I audible?
Yes, sir.
Okay, so it's a very nice and very excellent elucidations by Prasanna, and I think this particular thing is very important. That's why I uh, I talk to my students and others that thickeners are very important, because this texture analysis of the food sequencing and this food is very important, not only for this head and neck cancer and also for the neurogenic cancer, neurological disorders for dysphagia. So this particular presentation is very excellently described by Prasanna. So I thank Prasanna Hegde for this very excellent presentations, very knowledgeable presentation, because he is the person who is doing a lot of work in this particular country, and developed so many other organizations, and who are also doing a lot of good work in the field of dysphagia and deglutology. And I also thank this Nestle company, because without this particular company effort, especially this Orijit and other person who are also there in that Nestle part, they are continually supporting me and also my team when we start talking about this particular aspect, because it is compared to new thing for these SLPs group, for this particular things to address, but it is nicely made. So I think the next also you will get the support from you all, and to also we can use so many other uh, protocol and discussions in this particular aspect. I, on behalf of Speech and Hearing Association of India West Bengal branch IWB, there is an West Bengal branch of Isha. I thank from my heart, from my core of my heart, that that particular topic, which is an excellent topic, and that I thank to all of you, all the participants, and hope this particular topic will be there in the ISHACon, that is called pre-conference workshop. This is the collaborative effort we are doing along with the IDC, that SLP Quest. And Prasanna Hegde is the person, the key person, who is actually the instrumental for developing these particular things. And we are looking forward. Please register, all of you who are there. Please register and please join and these particular excellent sessions in the ISHACon. And I welcome everyone for this. Thank you all. Thank you, Prasanna. Thank you, Orijit, Nestle team, and Orpita, and all participants who are listening to this particular thing this Sunday. Thank you.
Thank you very much, sir.
Thank you very much, General sir.
Thank
And
you, everyone.
again, sir, it was a wonderful opportunity for all of us as well to have such a warm cloud and such an interesting discussion. And every time I hear Prasanna sir, we all are every time mesmerized because of his the way he presents the scenario, and with the help of this case study, he makes the entire process and entire presentation so much easy and interesting. So, Prasanna sir, thank you once again from our side to
Thank you.
discuss this thing. And again, Thicken Up Clear is the product that Nestle brings in this country to help your patients who are suffering from dysphagia and other related problem related to this. So any other thing related to this, we are always there to support all the group related to speech and swallow therapies. And from Nestle, we'll be really thankful to each and every one of you. Thank you. Thank you.
Thank you all.